Good morning. Today it is my pleasure to present on the topic of when to punt, damage control strategies for diverticulitis. I have nothing to disclose. As we all know, diverticulitis represents a pathologic outpouching of the mucosa and submucosa, generally through the areas where blood vessels permeate, predominantly the sigmoid colon, but anywhere within the colon. The diverticulum that you see on the left screen is the gross picture of diverticulitis, whereas the endoscopic picture demonstrates some feculent matter retained within the orifices of the diverticulum. And as we all know, diverticulitis, or the inflammation and or perforation of generally sigmoid diverticulitis, has been classified by Hinchey into 4 different classifications: localized pericolic abscesses, distant retroperitoneal and or pelvic abscesses, periodontitis, which represents frank perforation, and feculent peritonitis, which represents frank perforation with stool within the peritoneal cavity. This position paper goes over the overall management of diverticulitis, briefly commenting that stage 1 can be successfully observed and discharged. And if they cannot be successfully observed, they can undergo definitive resection either during that hospitalization or at a later time with recurrence. Stage 2, which is the localized abscesses, generally in the pelvis, can be managed with interventional radiology drainage. And again, if that is successful, those patients can be observed. However, if the abscesses are recurrent and or the drainage strategy is unsuccessful, the patient can be referred for a definitive resection. Stage 3 and stage 4 diverticulitis, which is the purulent and feculent peritonitis, the next discriminator really depends on septic shock, and it's the population that is in septic shock that I will be focusing on further. But those patients without septic shock can undergo either laparoscopic or open resection and or lavage and drainage, depending on the patient's physiology and their ability to sustain a second hit, as lavage and drainage is associated with more episodes of non-operative failure. And then in those patients who are in septic shock, we can talk about damage control laparotomy. So I'm going to focus the remainder of my talk on Hinchey 3 and Hinchey 4 diverticulitis, where the more complex surgical decision-making is required. Patients who present with generalized peritonitis due to diverticulitis, i.e. Hinchey 3 and 4, have a mortality that approaches 40%. And for years, the Hartman procedure has been considered the gold standard for treatment of this disease process. However, fully 30% of patients never undergo stoma reversal, and maintaining a stoma can be problematic as it may impact the patient's personal body image and or have associated complications like stomal hernias. What has happened over the last several years is that resuscitation strategies and ICU management strategies have improved, so Hartman's procedure may no longer be considered the gold standard, and we are going to discuss that. Drivers to consider switching to damage control strategy include the presence of extreme comorbidities and severe sepsis and or septic shock. And I want to talk a little bit about surgical decision making. In patients who have high risk problems and you have little time for decision making, an intuitive or recognition primed approach to decision making is important. This is an automatic reaction to the patient's disease processes with little conscious deliberation. However, I submit to you that when you are managing the patient with stage 3, stage 4 diverticulitis and septic shock, oftentimes there is enough time to consider an analytical approach or an options-based comparison. And we're going to walk through some of those option-based comparisons. A brief discussion about damage control surgery and damage control resuscitation. As you are aware, damage control surgery was created in response to the trauma population and represents an abbreviated laparotomy with control of hemorrhage contamination and temporary abdominal closure, followed by aggressive ICU resuscitation. And particularly in the trauma population, damage control resuscitation involves the minimization of blood loss, early goal-directed resuscitation with blood and blood products to maximize tissue oxygenation and improve outcome. The goal of damage control resuscitation to avoid the triangle of death, or the lethal triad of acidosis, coagulopathy, and hypothermia. So when we think about damage control surgery in the management of perforated diverticulitis, we're talking about predominantly 3 operations on the lower portion of this chart. And in this presentation, TAC is not total abdominal colectomy, but rather temporary abdominal closure. So in patients who present with Hinchy 3 or 4 diverticulitis in whom the patient is stable, and again, depending on surgeon preference and surgeon decision-making, washout with closure of the diverticulum is feasible. Primary anastomosis with or without diverting loop ileostomy is probably preferable based on some data that I'm going to show you shortly. And a Hartmann's procedure is also feasible, but again, 30% do not get their stomas removed or taken down. It is the population that is hemodynamically unstable that falls into the damage control mode. And these patients can be considered for a Hartmann procedure, a limited resection with discontinuity and temporary abdominal closure with a second go-round in the operating room with either a Hartmann or a primary anastomosis, or just washout drainage and a temporary abdominal closure with definitive surgery at a later time, depending on the patient's hemodynamic status. And what are some of the types of temporary abdominal closures that we can use in the year 2020? Well, the most common one in trauma for early laparotomies is the backpack dressing or the Barker dressing, which is basically a fenestrated bowel bag placed over the enteric contents, followed by 2 10 flat jacks and Pratt drains, a blue or a white towel, and an Ioban dressing. Another option is the KCI wound vac and its derivatives. In this patient, you can see there's a significant loss of domain. So the wound vac was placed over a larger segment of bowel, again, over a fenestrated drape. And in this patient, a combination of skin-only closure and a vacuum pack dressing was placed to minimize loss of abdominal domain. So let's go through a couple of cases. This is a 50-year-old female who is an active smoker who had failed non-operative management. She had had multiple residual collections in her pelvis despite several attempts at percutaneous drainage. At the time of presentation, she had evidence of localized but not generalized peritonitis, but was hemodynamically normal. Based on what I told you, this patient falls in the top categories of being hemodynamically stable, not requiring damage control laparotomy, and being a Hinchy 3 classification. So in this patient, because she was a Hinchy 3 and not septic, my options were a primary anastomosis with diverting loop ileostomy or a Hartmann procedure. And I prefer to try to do a diverting loop ileostomy if I need a stoma, because they are so much more easily tolerated at the time of reversal and do not require a repeat laparotomy. Because of the location of the abscess cavities in this patient, I did not feel that I could do a primary anastomosis safely outside of the field of contamination. So I protected that anastomosis with a diverting loop ileostomy, which was reversed successfully at 6 weeks. And the data to support this decision is a systemic review and 2 multi-center trials that demonstrate equivalence of Hartmann procedure and primary anastomosis in terms of morbidity in the management of the hemodynamically stable patient, as you can see on this graph, with an odds ratio less than 1. The second case I'd like to discuss is a 75-year-old male with multiple comorbidities who failed non-operative management, was found on a repeat CT scan to have areas of pneumoperitoneum and a new pressor requirement. This patient falls into the category of a Hinchy actually 4 classification based on operative findings. He was hemodynamically unstable, and we elected to perform damage control procedures. In his cases, the options were Hartmann, resection discontinuity and attack, and washout drainage and attack. Despite the fact that he coded on induction of anesthesia, he was resuscitated aggressively in the operating room and on 2 pressors was able to tolerate a Hartmann procedure, which lasted about 45 minutes, and he returned to the ICU with an abdomen that was closed and a definitive surgical procedure. One of the things that impacts decision-making about diversion versus non-diversion is the Mannheim peritonitis index, which you can appreciate here. This patient had feculent peritonitis. He had diffuse generalized peritonitis, which brings him up to 18. He got a score of 4 here for 22 and was greater than 50, which brought him up to a score of 27, which has a overall mortality risk of about 30% in all comers. Unfortunately, this patient had significant comorbidities as well, including an underlying malignancy, which brought his morbidity or likelihood of mortality to 75%. So I thought a rapid operation that was definitive would be better. However, in preparing for this talk, I identified this paper that was published recently, 34 patients, 62% of whom had Hinchey 4 diverticulitis with a mean Mannheim peritonitis index of 25. They did 2 separate procedures. One was all patients underwent damage control laparotomy and temporary abdominal closure. So they had an initial resection, they were washed out, and they had a temporary abdominal closure, and then 48 hours later, they were taken back to the operating room. 71% underwent a successful primary anastomosis, only 10% of those required diverting loop ileostomy, whereas 30% underwent a Hartmann procedure, and their overall mortality was very acceptable at 12%. So in retrospect, damage control surgery with primary resection and a washout, but not actually moving forward to complete the Hartmann procedure and then coming back at a later time to determine whether or not the patient would benefit from a primary anastomosis with or without diverting loop ileostomy or a Hartmann procedure is also a feasible option in the management of patients with Hinchey 3/4 diverticulitis and sepsis. So in summary, while the Hartmann procedure has been the gold standard, I submit to you that primary anastomosis with or without diverting loop ileostomy and or damage control strategies with a later primary anastomosis may be the best way to manage some of these patients who present in extremis and require damage control interventions for the management of perforated diverticulitis. I would like to thank SAGES and the program committee for the opportunity to present these data, and I would be more than happy to answer questions that are not answered in the panel discussion via email, kimberly.davis@yale.edu. Thank you very much.